Welcome to Omnicurus Originals. We are celebrating the Diabetes Awareness Month, and today we have Dr. K.C. Lohani with us. Dr. Lohani is the present chairman of RSSDI Uttarakhand chapter and the founder chairman of API Uttarakhand chapter. He is also the past president of IMA Uttarakhand chapter. He's one of the senior-most diabetologists of Uttarakhand, and he started gastrointestinal lab, the first diabetic clinic, epilepsy clinic, biochemistry lab for the very first time in rural areas of Kumaon region of Uttarakhand. And since then, he has been holding many medical composite health camps at distinct villages in Uttarakhand state. He's also actively involved in Aao Gaon Chale programs, school health programs, senior citizen clinics, and Asha Deep Institute Home, which is a program run by Mother Teresa Group of Missionary. We are very pleased to have him today with us, speaking on this special topic, euthymia in diabetes. Welcome, Dr. Lohani. The stage is all yours. You may please begin.
And I welcome you on this seminar of this today's event. And my topic is euthymia in diabetes. I feel it is a new subject, though it is very old since last many years. We know all these things, but it has been discussed in very less time. This presentation will cover the following things: burden of diabetes distress in type 1 diabetes and type 2 diabetes patients, and differences between major depressive disorder and diabetic distress, and comprehensive approach for screening and diagnosis of diabetic distress, targeted areas and treatment approach in the patient with diabetic distress. And this lecture was taken from this euthymia in diabetes, clinical evidence and practical based opinion from an international expert group. And what is euthymia in patient with diabetes mellitus? The understanding concept of euthymia in diabetes. Euthymia referred to the optimal mental state or mood and as an essential part of good health and well-being. The word euthymia, eu means well, thymos means soul. Emotion was first defined by an Greek scholar, Democritus, as a one satisfied with what is present and available, taking little heed of people who are envy and admire, and observing the lives of those who suffer from and yet endure. The euthymia could be broadly described as a state of positive mental health, ensure and psychological well-being. The euthymia should be considered as an important tool and target in diabetic care, as the burden of mental health dysfunction in high as in diabetic patient. Overview: burden of diabetes distress in diabetic patient, and the understanding of hidden struggle of living with diabetes. Diabetes mellitus has a profound impact on both the physical and mental well-being of the affected individual. Diabetes-related emotional distress is associated with burden of self-care, interpersonal issues, emotional worries regarding the ability to cope with the illness, relationship with caregiver and healthcare professional. And what is the definition of diabetes distress? Diabetes distress is defined as an emotional response characterized by extreme apprehension, discomfort, or dejection due to perceived inability in coping with the challenges and demand of living with diabetes. Diabetes care professional must work to identify the cause or the etiopathogenesis of the diabetic distress and minimize its impact. And prevalence of diabetic distress in patients with type 2 diabetes. Diabetic distress is a major concern of type 2 diabetes, with a higher prevalence noted in female gender and patients with comorbid depressive symptoms. The overall prevalence of diabetic distress noted in meta-analysis of 55 studies, and patients were type 2 diabetes were about having 36% of this problem. And prevalence of diabetes distress in adult and adolescents with type 1 diabetes. This we discuss in type 2 diabetes. And now in type 1 diabetes, in a study, prevalence and 9-month incidence of elevated diabetes depression distress was reported in 42.1% and 54.4% respectively in type 1 diabetes patients. And the time point in diabetes mellitus patient associated with increased level of diabetes distress, identifiable period during which patient have the probability of high level of distress about their life with diabetes. What are these things? Around the time of diagnosis of type 1 diabetes, at the time of learning how to self manage diabetes, at the time of a complication, at the time of switching medication and health care plan, at the time of switching healthcare providers. These are the different times when patient is in distress. And diabetes distress or clinical depression is a major depressive disorder. How to elucidate the confusion? Coexistence of depression and diabetes. Diabetes depression or major depressive disorder is a complex, debilitating condition and frequently coexists with diabetes mellitus. Prevalence of major depressive disorder is approximately 3 times higher in patients with type 1 diabetes than the general population, 12% versus 3%. The prevalence of major depressive disorder is nearly twice higher in diabetes mellitus patients than those without diabetes. It is 19% versus 10%. The patient with diabetes mellitus and major depressive disorder have very poor health outcome and high mortality rates. In diabetes distress, same as clinical depression. Diabetes distress is not same as clinical depression, and unlike depression, diabetes distress is persistent over time, associated with glycemic control and disease management, expressed in terms of magnitude, severity, and content, and difference between diabetes, major diabetes depression distress, and diabetes distress. And definition, and as in major diabetes depression, define the presence of at least 5 of the 9 well-defined symptoms that persist for a period of 2 weeks. While in diabetes depression, by contrast of diabetes and its management, and include a wide range of emotional experience. Assessment and management is based on patient symptom, while in diabetes distress, based on source of diabetic distress. Association with psychiatric illness considered as a comorbid psychiatric disorder in major depressive disorder, while in diabetes distress is not considered as a separate condition, mediating psychological form of a part of spectrum of diabetes mellitus. Differences in symptoms between depression and diabetes distress. The 5 or more of the below mentioned symptoms should be present over the last 2 weeks and represent a significant change from the baseline functioning. What are these? They are depressed mood, diminished interest, pleasure in daily activities, changes in appetite, insomnia or hypersomnia, psychomotor agitation or retardation, fatigue, feeling of worthlessness or guilt, diminished concentration. And what are the symptoms in diabetes distress? It is a emotional response varies across different patients and may include any of the below mentioned response, such as feeling of unmotivated, burnout, overwhelmed, frustrated, angry, guilt, fear of hypoglycemia and other complication, and loneliness. And difference in measurement of depression and distress in diabetes mellitus patient. In depression is measured using several approaches in diabetes literature. They are diagnostic and statistical manual of mental disorder criteria for major depressive disorder. Patient has questionnaire and Center for Epidemiological Studies of Depression scale. There are scales, some part of the scale we will be discussing later on. And while in diabetes distress, measurement of diabetes depression is contest of specific and more straightforward. The problem areas in diabetes or diabetes distress scale. We have a scale for diabetes to measure the diabetes distress also. The measurement of depression and distress in diabetes mellitus is important owing to high prevalence of comorbid disorder and persistence of depressive effect and diabetes distress over time. Screening and diagnosis of diabetes distress in diabetes mellitus patient and need for development of diabetes distress scale. There are some limitations also. Some critical areas of interest are not covered adequately, either too brief nor covered at all in these measures. Some, some items in measurement may be confusing for a patient to understand. Measures are not brief. Some measures are brief but do not have subscale. So diabetes distress scale was developed to address the limitation of earlier screening scale and to use a time difference tool to screen patients with diabetes related distress. Now we have mainly type of scales. One is two item diabetes distress screening scale. It contains only two feeling of overwhelmed by the demand of living with my diabetes and feeling that I am often failing with my medicines and it is a mild problem, it is a moderate problem, and these are the numbers they have given. And diabetes distress scale lists two potential problem areas that people with diabetes mellitus may experience and at in assessment in a level of distress with regard to have two items in the patient during past month. And the other scale is the 17 item disease distress screening scale, and they have mentioned there are questions like this, and the diabetes distress scale lists 17 potential problem arise that people with diabetes mellitus may experience and add in the assessment of level of distress with regard to those 17 items in the patient. And they are the patient are required to consider the degree of level to which each of the item included in the scale may have disturbed him or her during the past 1 month and then to circle the appropriate number. Diabetes distress scale 17 at in identifying major source of diabetes distress, and major source of diabetes distress are powerlessness, negative social perception, friends or family distress, physician distress, hyperglycemia distress, management distress, eating distress. They are main factors. And pattern of relationship between diabetes distress 17 and diabetes variable association between 3D study and diabetes DDS 70 scale, the key diabetic variability and SbA1c, self-efficacy, healthy diet and physical activity. A consistent pattern of curvilinear relationship was noted between the diabetes depression scale 17 and diabetes variable. The slope increases linearly between the score 1 and 2 was more muted between 2 and 3 and reached the maximum between 3 and 4, suggestive of 3 patient subgroup. And they are what are these? Coping skill assessment, primary investigation for diabetes depression prevention and treatment. These 6 coping style they are negativity, blame, acceptance, optimization, planning, and action. And how to manage these patients by which intervention strategies? Because we have in diabetes distress we have some oral presentation to the with the patient conversation. You have to find out what is the cause behind this. If you suppose he has problem with his meals, sometime patient has problem by injection, sometime he has problem with daily medications and other activities of the life. Approach to managing diabetes distress is self-perceived sufficiently by coping skill. Hence, most management approach need to be focused on the individual, improve self-perception, improve coping skill, minimize the burden of need to be coped with, involve other partner in coping. And diabetes therapy by the ear. Ear means you have to talk to the patient, strengthening self-care skill, healthy diet habits, being physically active, self-administration of the oral or injectable. Many times patient they take, today I got a patient, I asked him what medicine are you taking for his diabetes. He said, I don't know. He was a learned man. He was not a illiterate person. He was saying that my wife give me medicine and I eat it. And I don't know what is that medicine. So this type of problem you may also face, a self-monitoring of blood glucose level. And because many times they go to some other person, yeah, some other member of the family, and they help them to measure their blood sugar. And strengthening of essential, we should strengthen them to take their diet properly, to administer, to take their medicines either oral or insulin by themselves, and they should do physical activity of their own, and they should monitor self so that they will not have any problem when somebody is not available there, and then they will be at a risk for not getting proper treatment. Diabetes therapy by ear, coping skill enhancement approach asks to assess the coping skill, eliminate negative coping skill, internalize positive coping mechanism, observe an ongoing basis, upgrade one's understanding. And diabetes therapy by the ear, minimizing discomfort of change. Diabetes care constitute multiple changes impacting every fact of the life, eventually caring, stress, discomfort, and new challenges. The method of minimize discomfort of diabetes with change caused by diabetes are breaking the change suggested into uh, discrete discrete bites, prioritizing action for change, focusing the essential, making complete use of human resource and technology. So we have to listen the patient, we have to explain him why he has to do this thing. And then I think his stress will be relieved. Diabetes related emotional burden, physician related, because many times physicians do not hear them properly, so that make them upset. Ki, now how I will do this, how I will do that. And regime related distress. If you prescribe so many medicine, they are confused. So I think these combined medication, and sometimes we should write less medicines, better if they are combined form. That will help them to relieve their stress. A person is taking 10 tablets per day. It is very big burden, mental burden. So we should make the tablet number less. Interpersonal distress, they have some their personal problems also. Diabetes distress, multidisciplinary treatment, emotional burden, coping strategies by diabetes educator, followed by care of diabetes knowledgeable psychological and psychological treatment by mental health professional, and interpersonal distress, promotion of health behavior, and treatment of psychological problem, care setting, diabetes clinic, mental health professional setting, and diabetes clinic and mental health professional setting. This is very important. And diabetes distress multidisciplinary treatment approach, regime related distress, self management care, intervention delivered by diabetes educator, diabetes specific nurse, dietitian, and diabetologist. Care setting by diabetes clinic and diabetes support group. Physician or healthcare relative distress, provision of good clinical care, primary care, and specialist service. Clinical pearls and recognizing diabetes distress, the alarm bell. Physician need to be looked out for certain sign and indicate a patient state of mind and his or her potential to cope with the diabetes. Suppose there is sudden fluctuation in HbA1c level, major life change, and emotional reaction by negative result. So we have to explain them and helping patient cope with the distress, listening to patient and identifying underlying feeling can help manage distress properly. Helping patient talk about the experience of having diabetes, identify and specific source of their distress, normalize this feeling, help patient cope with distress as part of regular diabetes care. If you listen them, if you advise them properly, and you give some time to this patient, it may be 1 to 3 minutes, not too much time, but this will definitely give a better understanding between patient and physician. And key message of this talk: diabetes distress refer to emotional response encompassing extreme apprehension and discomfort consequent to perceived inability to cope with challenges of living with diabetes. Differentiation of diabetes distress from clinical depression is crucial to implement appropriate treatment strategies. Identification and cause of distress and optimization of practical aspect of diabetes distress management contribute for overall health and well-being of the affected individual. Many times I have seen when I prescribe patient insulin that many patients they start weeping in the clinic. Ki sab, now my end has come, and after insulin nobody survived. This is the general feeling in the patient. Suppose if we tell them, no, this is your friend and this will help you and it will save your kidney, it will save your heart and it will do all things. You explain them, you give some time to these patients. And after some time, these patients, they come with smiling face and all this. So this is my experience since last 44 years I am working in this field. And I have seen large number of diabetic patients. And since I have started a diabetic clinic here for the first time, that was the first conception that this is also a thing where I used to see large number of patients there. But that gave me a good experience. Thank you. I hope you got some idea how these patients they suffer with this mental disorder, and sometimes they go in depression. And if you talk to them, if you listen them, and the family also support them, then this problem will not come. This will be solved easily. Thank you.